So our next speaker is Dr. Chukwuma Egwim. I hope I'm pronouncing that right. He's a gastroenterologist and transplant hepatologist here at Houston Methodist. He specializes in liver disease, transplantation, hepatitis C, fatty liver disease, and hepatocellular carcinoma. As the Director of Post-Acute Care, he focuses on improving continuity of care and patient outcomes, so important. His work centers on delivering comprehensive, evidence-based treatment for patients with advanced liver disease and those undergoing transplantation. Can we give him a big round of applause?
All right, thank you so much for the invitation to be part of this very important conference, Lunch and Learn today. And you'll find that there may be some overlap in our presentations, but this just helps to emphasize or re-emphasize some very important points. So with respect to hepatocellular carcinoma, my objectives are to discuss what is it, how does it develop, why early detection matters, and risk reduction. So hepatocellular carcinoma is the most common form of primary liver cancer. So when we say primary, we mean the cancer that is originating in the liver, because there are various cancers that when they spread from other organs can go to the liver. So when we talk about liver cancer or primary liver cancer, these are cancers developing in the liver. Dr. Galati really did a great job going over the anatomy. And so the primary working cells of the liver are the hepatocytes. Hepato's liver, cytes, cell, hepatocytes, because you have the cells of the bile ducts, you have some cells of blood vessels in the liver. Hepatocellular carcinoma is cancer that develops in the primary working liver, the liver cells, the most important cells carrying out the function. 85 to 90% of cases of liver cancer are hepatocellular carcinoma. As Dr. Galati had mentioned, it usually develops in patients with chronic liver disease. So when we're talking about treating HCC, hepatocellular carcinoma, we're dealing with two different diseases, and that's what makes it unique. So not only treating the cancer, but you're having to contend with the underlying liver disease, in a lot of cases cirrhosis, and that in many cases determines what kind of therapies a patient may be eligible for in terms of their treatment. So one of the things that's unique with HCC is that it often develops in patients who have some kind of chronic liver disease, as Dr. Galati had gone over. So 80% of patients who have HCC have cirrhosis, and it's primarily linked to inflammation, fibrosis formation, most commonly now fatty liver disease or viral hepatitis or alcohol-associated liver disease. How common is it? It is the sixth most common cancer worldwide. It is the third leading cause of cancer death worldwide. In the United States, the rates of HCC have been climbing over the last few decades. And so this is, it's a small graph, but really kind of depicting that. And it's projected to continue to rise over the next coming decades. What is driving this increased incidence in HCC? Really, initially, the last few decades, it was more chronic hepatitis C. Worldwide, probably chronic hepatitis B, but we've come in this era where we have cures for hepatitis C. And right now, that's really largely, HCC is largely being driven by fatty liver disease. As Dr. Galati mentioned, the obesity epidemic, metabolic syndrome, meaning overweight, obesity, diabetes, high cholesterol, hypertension, resulting in fatty liver disease. And that is the fastest growing sector of chronic liver diseases that accounts for our new cases of HCC. Alcohol-related liver disease is still on the rise, the alcohol consumption. And as we find our patients with cirrhosis who are living longer, then the incidence of HCC is also increasing. How does HCC develop? So we're talking about pathophysiology, how it develops. And Dr. Galati really already kind of went over this, but really just to emphasize that it occurs in that setting of that ongoing inflammation. As we said, 80% of the cases of HCC are in patients who have cirrhosis. So these are patients who've had some kind of chronic liver disease, regardless of the cause. And he mentioned the various causes. Anything that causes inflammation for a long enough period of time eventually results in that scar formation, fibrosis in the liver. And What happens is that the normal cell replacement, cell replication that occurs that is dictated by the DNA, as Dr. Galati said, the marching orders that the cells have on how to behave, with this ongoing inflammation over time and that scarring, that results in some damage to the DNA, mutations. And these mutations then cause these cells to escape, so to speak, from that instruction, and they begin to replicate out of control. And you have these cancerous cells that develop and start to grow and spread uncontrollably. And that is how, in a nutshell, how HCC develops. So it starts in the liver, we've said, primary liver cancer. And these could be sometimes one tumor, could be multiple tumors. Each of these tumors eventually grow, and then they can get into the blood vessels right by the liver, the portal vein, and then by so doing, that's how that spread may occur. So as HCC progresses in its more advanced stages, it can spread outside of the liver. It can get bigger in the liver, then spread outside of the liver to the lymph nodes right near the liver, then more commonly to the lung and the bones in the more advanced cases. So an area, opportunity to reemphasize what Dr. Galati already mentioned, who's at higher risk? We've said that 80% of cases of HCC occur in those who have cirrhosis. Fatty liver disease is the biggest driver now for the new cases of HCC that we see. Viral hepatitis, B and C, excess alcohol intake, diabetes or obesity. We do know that men are 2 to 3 times more common or more likely to develop HCC than women. Age over 60 and smoking are risk factors for HCC. How about the symptoms of HCC? The most important thing to mention here is by the time symptoms develop, HCC is far advanced. We cannot rely on symptoms. When patients come in with symptoms, that indicates an HCC that is very advanced. Some of the symptoms that a patient may experience would be abdominal pain and swelling, abdominal distension with fluid buildup, fatigue, weight loss, jaundice, the yellow coloration of the eyes and the skin. But again, we cannot rely on symptoms because at that point it's late. These are various treatment options, and our colleagues will be going over this in more detail later, but there are surgical options to remove the tumor, transplantation, ablation and embolization, and various immunotherapies and targeted therapies. But the most important thing, which is really, I'd say, the emphasis of my message or my talk today, is that early detection matters. HCC can grow quickly, and early tumors or tumors that are detected early have the highest chance of cure. And when we talk about surgical resection in those whose livers are healthy enough to have a part of it removed, or for tumors that are still just within the liver, without going into detail, certain size that can have the whole liver swapped out in transplantation, gives the highest chance of cure. So if a patient can undergo resection, their 5-year survival rate is as high as 90%. If they are candidates for liver transplantation, their 5-year survival rate is 75% or higher. And compare that to a patient who has advanced cancer, that means it's now spread outside the liver in other organs, the 5-year survival rate tends to be less than 20%. Now, there are been a lot of development of new therapies, and our colleagues will kind of go over that, which are increasing those survival rates even for advanced cancer. But we have the best shot for cure when the cancer is detected early. So what are the strategies for early detection? Screening. Anybody who is known to have cirrhosis needs to undergo screening, and Dr. Victor will go into this a little bit more. But an ultrasound, some kind of imaging of the liver every 6 months with a blood test with a tumor marker called alpha-fetoprotein. The idea is to detect the cancer, the HCC, before any symptoms appear. So really, when we talk about treating cancer or managing cancer, the first step is, are we able to prevent it? Then are we able to detect it early? Should it occur? Can we detect it early so we have more treatment options? And so really talking about cancer prevention, many people who have chronic liver disease are not aware that they have that because they don't have any symptoms. We know that cirrhosis greatly increases the HCC risk. Now, if we can make a diagnosis early, then we can have patients treated for whatever the condition they have, whether it's viral hepatitis or fatty liver disease or whatever it might be causing the inflammation. If we can detect it early, we might actually be able to treat them so that it does not progress to cirrhosis and the cancer risk is low. And by so doing, we prevent liver cancer. And then if patients do progress to cirrhosis, then they are being monitored and having the screening protocol every 6 months, for instance, so that if it does occur, it can be diagnosed early. So how can we reduce our risk for hepatocellular carcinoma? Just piggybacking on what Dr. Galati has already mentioned, maintaining a healthy weight, with the diet and exercise, controlling diabetes if a person has diabetes, limiting alcohol intake. These are all things that are going to contribute to inflammation in the liver, hepatitis, as he mentioned, and ultimately fibrosis to cirrhosis, avoiding risky behaviors that may put one at risk for viral hepatitis. If a patient has hepatitis B or C, getting that treated. And for those who need the vaccination for hepatitis B, making sure that they get vaccinated. A big point I want to make here is that one of the best ways we can prevent liver cancer is just keeping up with our annual health checkups. You know, there are a lot of people who say, I haven't seen a doctor in 30 years, and they wear it like a badge of honor, like it's something to be proud of. I can't tell you, and our colleagues will probably say the same thing, how many patients come in with a diagnosis of HCC and they've never seen a doctor for 10 years, 15 years. What that means is that they had a chronic liver disease underlying that gradually progressed. They developed cancer, the cancer progressed, they developed symptoms, and now present finally at a late stage. So please, please, this is a message for everybody in this room, for our loved ones. It's not something to be proud of that you haven't gone to see a doctor. If we go once a year, the liver panel, the liver enzymes tend to be part of a standard annual physical. And we may be able to, your primary doctor may be able to pick up some illness, disease, whether it's some form of hepatitis or fatty liver. In some cases, patients may need to be screened for certain diseases. You know, lately, over the last, I want to say 5 years or so, now the guidelines are that every adult in the US over the age of 18, should be screened for hepatitis B and hepatitis C at least once in their lifetime. And so a person with hepatitis C or hepatitis B without symptoms can be picked up that way. And as we talked about, get treated, prevent progression of disease. So please, that is a take-home message here from my talk. Talk to your friends, your loved ones, your family. Go see your doctor. That way, if you have liver disease, that is diagnosed. And so just to summarize, most HCC, the majority of HCC occurs in patients who have chronic underlying liver disease. There are no early symptoms. Screening saves lives. If we're able to detect liver disease early, we can treat it and maybe prevent HCC. And we have more options of treating HCC when we diagnose it early. Thank you.